So my name is Rob Sims. I'm from Boston at the Boston University Scleroderma program. And what we're going to talk about today is autoimmune disease. And later on, we'll get to the autoimmune components that are relevant to scleroderma, obviously why we're here. But the lessons about autoimmune disease in general, I think, are worth reviewing, because that really informs us about how we think about managing the disease. So the lessons that we learned from animal models of autoimmunity really, over the last decade or so, have educated us about the mechanisms in human autoimmune disease in general, and in scleroderma in particular. And I think that's provides a lot of fodder for us as we investigate the disease and try to understand the mechanisms that can help us design therapeutic agents. So with that, here are my disclosures. I do consulting work and receive grant money from a number of industry sponsors as well as the NIH. A little primer on scleroderma. Of course, it means scarring in the skin, derived from the Latin sclero and derma, meaning skin. And as I've suggested, thank you for moving up closer. I'm stuck here. Otherwise, I'd be on the floor with you guys. But I'm told in order for them to do the videotaping, I have to stay up here. So scleroderma shares many features with more common autoimmune diseases like rheumatoid arthritis and systemic lupus. Those are sort of the big three autoimmune diseases that affect humans, at least. They have in common, at the most basic level, the presence of antibodies to self-antigens. So that's sort of really a key what's called pathognomonic feature of autoimmune disease, is the presence of autoantibodies. Now, the sort of the puzzle that we grapple with as investigators trying to understand scleroderma, which in many ways is, although it shares many features with other autoimmune diseases, it has some relatively unique features. And the scarring that characterizes the disease in the skin and in other organs is really not seen in any of the other autoimmune diseases. You certainly can see pulmonary fibrosis, a relatively common complication of scleroderma in rheumatoid arthritis. But you don't see the widespread fibrotic thickening in other organs and in the skin that characterizes scleroderma. In addition, there is this relatively unique feature that includes vascular abnormalities, such as Raynaud's phenomenon and pulmonary hypertension. Those are not seen in, or at least pulmonary hypertension is not seen in other autoimmune diseases, really, with any significance, certainly not to the level that it is in scleroderma. We do see rarely pulmonary hypertension in lupus. And you can see Raynaud's in both lupus and rheumatoid arthritis, as well as other autoimmune diseases. So I'm not trying to suggest these are completely unique to scleroderma, but they are much more common in scleroderma than virtually any other autoimmune disease. And as we'll see, autoimmunity itself is really the immune system gone haywire or gone awry. So again, the big three: rheumatoid arthritis, systemic lupus, and scleroderma. And the lessons that we've learned, particularly from rheumatoid arthritis and also from lupus, I think, help set the stage for developing an understanding of the disease that we think can propel us to more effective therapies. But there are many other autoimmune diseases that can provide us with information about how to understand and treat autoimmune disease. There's Hashimoto's thyroiditis, there's Graves' disease, there's Sjogren's syndrome, and a host of others that include inflammatory bowel disease, conditions like sarcoid, primary biliary cirrhosis, celiac disease, and type 1 diabetes. The list goes on. And some are considered more autoimmune than others based on the presence of specific autoantibodies. Inflammatory bowel disease, at least, doesn't really have a specific autoantibody, but it shares other features that are characteristic of autoimmune disease, including a genetic propensity, antigen-driven inflammation in a particular organ, namely the bowel, and that's also true of sarcoid. Sarcoid doesn't have an identifiable autoantigen or autoantibody that we know of, at least, but it is also considered an autoimmune disease, and it's treated in much the same way that all of the other autoimmune diseases are treated. So maybe one way to think about autoimmune disease is to imagine your immune system as a society of lymphocytes. And these represent your lymphocyte society, and we have millions and millions of these lymphocytes, of which there are many different subsets, but we'll keep it straightforward. These lymphocytes are sort of the primary actors of the immune system. And one among many functions, perhaps a principal function, is that they make antibodies. Now, these lymphocytes are manufactured in the bone marrow. They originally circulate through the thymus when we are infants, and that affects their processing into several different subtypes. And as I said, you have millions and millions of them that circulate in your peripheral blood, that percolate through your lymph glands and your spleen. Now, just like the society outside this hotel, there's a rogue element in the lymphocyte society that we all have. This is a little cartoon depiction of the major product of lymphocytes, which are antibodies. Antibodies are proteins, which are essentially little rocket-propelled grenades that take out viruses and bacteria and other invaders that are constantly trying to get into us. But as I said, in our lymphocyte society, there's a rogue element. And the rogue element in the lymphocyte world makes antibodies not to external invaders of our bodies, like viruses and bacteria, but it makes antibodies to self-antigens, so-called autoantibodies. Now, in people who do not have autoimmune disease, for our purposes, normal people also have rogue lymphocytes that make autoantibodies. The difference between having an autoimmune disease and not having an autoimmune disease is basically the number of those rogue lymphocytes. Normally, they're kept in check by a lymphocyte police force, and these are called T regulatory cells. And we think essentially that autoimmune disease occurs when the lymphocyte police force, the T-regs, if you will, go AWOL, like the LAPD perhaps a few years ago. Now, what is it that triggers the disappearance of the T regulatory cells it remains unknown. It may be a viral infection or another environmental exposure which does not leave any footprints for us to identify, but something happens to the T regulatory cells and the rogues begin to proliferate and they make large quantities of autoantibodies, antibodies directed against self, that then set off a cascade of immunologic events that lead to the autoimmune disease in question. So autoantibodies then are antibodies directed at self-antigens that are normally kept in check by a regulatory mechanism that breaks down for reasons that remain unclear but lead to uncontrolled proliferation of rogue lymphocytes and overproduction of autoantibodies that then become detectable. In normal people, while those antibodies are there, they're virtually undetectable, except under specific, highly sensitive research settings. But in autoimmune disease, those autoantibodies are actually detectable using commercial assays. And they tend to be specific to the disease in question. For example, in lupus, there are antibodies to what's called native or double-stranded DNA. That's the genetic material that we all have. And in lupus, that's a characteristic antibody feature of the disease. It's really a marker of the disease, if you will, and it's useful both diagnostically and in understanding how the disease actually works. In rheumatoid arthritis, there are other antibodies that characterize that disease. Those are known as anti-CCP antibodies. They used to be rheumatoid factors, but that's a different, completely different kind of autoantibody that characterizes rheumatoid arthritis. Now, so what happens when you make antibodies to self-antigens? Well, we think what happens is that those antibodies complex with the antigen. So in the case of lupus, antibodies to double-stranded DNA complex with DNA. And that complex then gets deposited in various target tissues and provokes an intense inflammatory response, part of an immunologic stew, essentially, that develops and then creates the manifestations of the disease in question. So, for example, in lupus, we know that antibodies to DNA complex with DNA. That complex gets deposited in various tissue sites, best demonstrated in the kidney. That in turn provokes inflammation in the kidney that we call glomerulonephritis, and that's a characteristic feature of lupus. And we've known that now for a number of years. So we talked about some of the characteristic autoantibodies in rheumatoid arthritis and in lupus. One thing about lupus is that in contrast to virtually every other autoimmune disease, there's not one or two characteristic autoantibodies. There are really many, many autoantibodies that characterize lupus. So it's sort of considered the prototype of autoimmune disease based on the number and quantity of autoantibodies that are produced. And there are animal models that duplicate many of the autoantibody features and types of lupus. We struggle with animal models of the other forms of autoimmune disease, and we struggle because they don't really duplicate the complexity that we see in scleroderma, the vascular features and the fibrotic features especially. So animal models are more challenged by scleroderma than they are perhaps for lupus and rheumatoid arthritis. And I think in some ways that's hindered our understanding of the molecular mechanisms of the disease, or at least delayed our understanding so that we are a little bit further behind in terms of developing really effective targets for therapy in scleroderma as opposed to the other two diseases, perhaps. These are some of the antibodies that are characteristic, though, of scleroderma. The kind of the screening antibody that's common to both lupus and scleroderma, as well as other autoimmune diseases that I haven't listed here, is the so-called ANA. And ANA stands for anti-nuclear antibodies. And those are antibodies that are directed against nuclear antigens within the cell nucleus. So those are, that's a screening antibody test for autoimmunity. If your ANA is not positive and you have scleroderma, it does raise the question about whether or not the diagnosis is correct. It's not uniformly present. Dr. Mays' group, I think, recently looked at her large cohort in identifying folks who had diagnosed scleroderma but who were ANA negative. And I think the number was fairly small, less than 10% of the entire population. So it's quite unusual to have ANA negative scleroderma. It does exist, but usually other autoantibodies are present. And some of the others include one known as anti-SCL70. There's anti-fibrillin. And these are sort of nameless proteins, many of which we don't really understand what that target actually is and what significance it has. But we have identified antibodies to those self-targets, and those seem to be characteristic of the disease in question. And there's also anti-centromere antibodies. This one is actually quite common. So about 90% of patients with scleroderma have ANA positivity, and then varying degrees of positivity to some of these other antibodies. We do think that they do hold some clinical significance. For example, antibodies to SCL70, which is a name for a scleroderma antigen number 70. It turns out to be an enzyme within the nucleus called topoisomerase. but it tends to be associated with interstitial lung disease in folks who have scleroderma. Anti-U1-RNP antibodies, ribonuclease, this is a protein within the nucleus, and antibodies to this particular protein seem to be associated with a higher risk of renal crisis in scleroderma. So they while we don't necessarily understand all the mechanistic events that associate these autoantibodies with the disease manifestations in question, we are able to recognize these as risk factors for certain types of disease manifestations. Let's talk a little bit more about SLE, and we've talked about a little bit about animal models of SLE, the proliferation or the number of different types of autoantibodies that are seen in SLE, and perhaps a little bit about the role of immune complexes. The concept of immunologic tolerance is one that has developed over the last decade or two in our understanding of autoimmune disease. Immunologic tolerance means the ability not to develop an immunologic response to a particular antigen. So immunologic tolerance is what we all have that controls our own propensity to develop antibodies or an immunologic response to self. Perhaps, a good example of immunologic tolerance is the immunologic tolerance that a mother has to her developing fetus, right? So the fetus contains a genetic complement which is foreign to the mother, at least 50% of it is, and the immune system has developed over the course of evolution immunologic tolerance to the fetus on behalf of the mother. The mother doesn't reject the fetus as a result of this immunologic mechanism known as tolerance. Well, the same process, we think, occurs and prevents the development of autoimmune disease in normal people. And understanding that control mechanism and how it breaks down is really central to our understanding of autoimmune disease. In the case of lupus, and particularly from animal models, it appears that one of the defects is a defective clearance of cells that die. We know that cells are constantly turning over. I forget what the exact rate of cell turnover is, but it's highly dependent on the organ. But your skin, for example, is turning over virtually continuously. Your GI tract is turning over. So there's a large amount of cellular debris that we have to get rid of. Sort of cellular garbage, if you will. Now, in lupus, we think that garbage clearance mechanism basically breaks down. You have release of many of these intracellular antigens that hang around too long, particularly DNA, and that triggers this immune response with antibody production when the immunologic police force that controls the mechanism of tolerance begins to break down. So there's substantial evidence for that, and this slide shows in a cartoon fashion how the formation of these immune complexes to DNA, there's a little strand of DNA, there's the antibody, this Y-shaped thing that attaches to the DNA. That complex then gets filtered through the blood and into the kidney, and this is a cross-sectional view of the filtering mechanism of the kidney. And we know that in animal models, these complexes get stuck in this basement membrane, basically the coffee filter you think of the kidney as essentially a coffee filter. What happens is that these immune complexes get stuck in that coffee filter of the kidney, the basement membrane. That provokes an immunologic reaction that leads to damage of the membrane, the basement membrane, that makes it leaky. It's like your coffee filter is full of holes, and that leads to protein release into the urine and eventually kidney failure. So this is a direct result of the formation of these immune complexes and the inflammatory response or glomerulonephritis that results from them. Now, renal disease in scleroderma, I should back up, is a different process. It's It's actually driven by the vascular system and not directly by the formation of immune complexes that clog up that basement membrane in the kidney. So it's a different problem. So I'm using this as an illustration of how these antibodies to self-antigens, though, in the case of lupus, tell us how they cause disease. Again, just to sort of flesh that out, it occurs in the glomerulus. It also occurs in the renal tubules, kind of the drainage system of the kidney. And there it appears that the antibodies to DNA actually not just form immune complexes that get stuck in the tissue, they actually directly interact with the cells that line the tubules in the kidney. Now, one thing that's characteristic of really all of the autoimmune diseases that I think is worth highlighting is the genetics of autoimmunity. And Dr. Mays has spent a good part of her career understanding the genetics of scleroderma, and she's published some seminal studies on twins who have scleroderma, and they are particularly informative about the genetic factors that play a role in scleroderma in particular. What do I mean by that? Well, twins, identical twins, have exactly the same genetic complement. They have all the same genes. And looking at the rate of concordance in identical twin studies tells us a lot about the genetic component to autoimmunity. Specifically, if you have an identical twin with scleroderma and the other member of the twin pair does not, we know from those studies now that the rate that the non-affected twin develops scleroderma over their lifetime is about 10%. So it's certainly not 100%. So even though that individual has exactly the same genetic complement, it's not sufficient to develop the disease. 90% of the time it doesn't happen. Now 10% is clearly a far higher risk of developing disease than someone who's genetically unrelated to that twin pair who has scleroderma. But it's not 100%. And it does vary throughout the autoimmune disease world. In lupus, it's as high as 40% disease concordance. In rheumatoid arthritis, it's kind of about the same level as we see in scleroderma. So what does that tell us? Well, it tells us that genes are very important, but they're not sufficient to develop the disease. A little bit more about the immune complex formation. Again, we think that this is the result of a defective clearance or buildup of these immune complexes in other organs, in the case of lupus in particular. And this shows immune complex deposition. This is actually an entire glomerulus, and this immunofluorescent uptake through an immunofluorescent microscope is a tag. So it's an immune fluorescent tag for these immune complexes, showing us where they get deposited throughout this filtering mechanism of the kidney on the left-hand side, and then in the skin of patients who have dermal involvement with lupus on the other side. So again, just really direct evidence that immune complexes produce clinical disease here in the case of lupus. Now, I apologize for this slide in a way because I know you just had lunch. But this is actually a patient with rheumatoid arthritis who is about to have a joint replacement in the finger. And I show you this slide because this blob here is actually synovium. And the synovium is the lining of the joint in rheumatoid arthritis, which is the target of the disease. So rheumatoid arthritis is an autoimmune disease that targets this innocuous little membrane in your joints, and it proliferates many hundreds or even thousands of fold times to produce this blob that can invade and degrade surrounding tissue and bone. Now, why am I telling you all this? And why am I showing you this kind of shocking picture? Well, because I want to make the point that in rheumatoid arthritis, this process is highly destructive. And it's the result of antigen and antibody-driven immune complex formation and the immunologic chaos that results from that. We're going to come back to rheumatoid arthritis in just a minute because I think it provides a model for how we can treat autoimmune disease, and perhaps without knowing exactly what the trigger for that autoimmune disease is. What I mean by that is that we can now dramatically alter the course of rheumatoid arthritis using targeted therapy at the signaling molecules that have gone berserk in this immune soup or stew without actually knowing what causes the disease. I'll get back to that. Before we do, though, I want to introduce immunosuppressive drugs. So the immune system is the problem. We've talked about the immunologic chaos, the immunologic stew that results in autoimmune disease. The conventional way to treat immunologic chaos or overactivity is to suppress it. And you can do it using some of these commonly available agents now, which have been around for quite a while. At the top of the list is methotrexate. This is widely used in autoimmune disease. It is modestly immunosuppressive. It's probably actually primarily anti-inflammatory rather than truly immunosuppressive. And that's just, what's the difference? It's basically a difference of degree, right? So the most modest anti-inflammatory medicines that we have available are ones that you can buy over the counter in any drugstore, right? So those are non-steroidal anti-inflammatory drugs like Advil or Naprosyn. They are anti-inflammatory that they block part of the inflammatory response that actually characterizes autoimmune disease. But they're not immunosuppressive because they don't suppress the overall immune system. They block a tiny portion of the inflammatory response. Methotrexate does a little bit of both. So it downregulates and suppresses the immune response, but it does it rather modestly. And its effects are primarily anti-inflammatory. That's also true of a drug called azathioprine or Imuran. So they're very similar in that respect. They differ somewhat in their side effects. And that's why we use them, sometimes actually in combination, but usually in isolation. Perhaps more commonly used now and more potent as an immunosuppressive drug on the immunosuppressive hit parade is mycophenolate mofetil is its full generic name. It's also known as Cellcept is the trade name. And it is more immunosuppressive than either methotrexate or azathioprine at the therapeutic doses. And it is actually widely used in scleroderma as well. There's an ongoing clinical trial, namely SLS2 or Scleroderma Lung Study Part 2, which is a randomized control trial comparing Cellcept with its more potent cousin, Cytoxan, which has been proven to be effective in slowing the rate of progression of pulmonary fibrosis and inflammation in the lungs in scleroderma. So that's an ongoing trial now, and we think, therefore, that this drug may be actually a substitute, sort of a kinder and gentler substitute than cyclophosphamide, kind of the traditional big immunosuppressive gun for autoimmune disease. But the stronger the immunosuppressive drug, however, the greater the risks. And the reason for that is basically collateral damage, and I'll get to that in a second. Corticosteroids are immunosuppressive at high doses. They're anti-inflammatory at low doses, so they can sort of go both ways depending on the dose. But all of these drugs, especially at the higher dose ranges in the most potent ones, are essentially immunologic B52s. So it's essentially like, at the higher doses at least, calling in an airstrike on your immune system. Now, that's both good but also possibly bad, because it targets not only the rogues that are the problem, the rogue lymphocytes, remember, that make autoantibodies, but these agents can also cause collateral damage to the good citizens in your lymphocyte society. And that may be a bad thing, because it exposes you then to risk of infection. So the good citizens, of course, make antibodies to viruses and bacteria, and if you take out too many of them, you get infections, spontaneously, actually. Now, that leads into kind of a segue into the use of immunoablation and stem cell transplantation. So this is sort of the granddaddy of the B-52 airstrike on the immune system, if you will. So if the immune system is the problem, then one potential solution that is now being increasingly used with aggressive and particularly severe early autoimmune disease in general, but also scleroderma in particular, is immunoablation with high-dose immunosuppressive therapy, followed by stem cell transplantation. Now, this is not the politically incorrect stem cells. Those are fetal stem cells. So this has nothing to do with that. These are adult, mature, what are called hematopoietic stem cells that can reduplicate or have the capacity to reduplicate your functioning immune system, and they circulate in your blood, and they're doing it right now. So you can actually isolate those stem cells that are circulating in our peripheral blood. You can freeze them. Then you can lay waste to the immune system with an immunoablative dose of pick your poison. Usually it's Cytoxan or cyclophosphamide. And then you put them back after you do that. And bingo, put a reset button or hit the reset button on your immune system. And within about 2 weeks, those cells find their way back. It's remarkable, really. You take these stem cells, you put them back into peripheral blood. They find their way back to your bone marrow, and they proliferate and reduplicate your immune system. So it's starting over again, essentially, with a brand new immune system. And this seems to be a very viable approach. We don't have time today to go into some of the details about the evidence for that, but let me just say that there's increasing evidence that this is both safe and effective for particularly severe subsets of people with autoimmune disease in general, but also folks who have scleroderma in particular. All right, I'm going to change gears a little bit and throw out a question. Are there any art history buffs here? I'm going to give you a hint. So he has rheumatoid arthritis. He doesn't have scleroderma. I'm going to give you another hint. You're getting closer. This is what he painted. This is called the Luncheon of the Boating Party. So he was an impressionist. He had such severe rheumatoid arthritis that he actually had paintbrushes strapped to the center of his palm. And he couldn't use his arms because his shoulders were involved. So he actually constructed a pulley system so he could only paint in about an 8 by 10 square. And this canvas is like 8 by 10 feet. So he had this elaborate pulley mechanism with his canvas moved around so that he could paint in that little square. Really remarkable story. Anyway, that's Auguste Renoir, who basically died from severe rheumatoid arthritis in the early part of the 20th century. Now, I'm bringing this up because this is the type of rheumatoid arthritis which we don't see anymore. And it's gone away as a result of therapy directed at specific targets within the immune system. When I started out as a rheumatologist about 30 years ago, we still saw patients like Auguste Renoir. And they've gone away. Why? Well, they've gone away because we understand the immunologic soup that leads to rheumatoid arthritis, particularly here in the center part of this soup or cascade of immunologic chaos, is a signaling molecule called TNF-alpha. And it turns out that through understanding that and the central role of TNF-alpha in rheumatoid arthritis, we know that TNF-alpha, for example, stimulates a cell type in the bone called osteoclast to erode bone and over a period of months or years damage bone and cause severe deformities. We know that TNF-alpha causes proliferation of the synovium that I showed you a picture of. That leads to chronic joint pain and inflammation, and also erodes and damages the intra-articular anatomy. And we know that TNF-alpha also stimulates cells in cartilage to degrade, leading to further joint damage over time. And over the course of the last 15 years now, we've developed the capacity to take out TNF-alpha, that central signaling part of rheumatoid arthritis that leads to disease like that which deformed and disabled Auguste Renoir. And this is an example of two of the available medicines that can do that. And they are essentially specific types of synthetic antibodies. So we can now manufacture antibodies that are directed against specific targets in the immune system. These are immunologic smart bombs, if you will. So this is not immunosuppressive therapy that broadly suppresses the entire immune system. This is immunosuppressive therapy that takes out a specific part of it without laying waste to everything else and without causing too much collateral damage. I'm not saying it doesn't have the capacity to cause collateral damage. We know that these agents actually do increase the risk of infections, but one is not a walking petri dish if you're on etanercept. So I asked you if there were any artists, or at least art historians. Are there any golfers here? No? So last week, there was this little golf tournament in Scotland called the British Open. Phil Mickelson won it from behind, and he takes this drug. So he has psoriatic arthritis. It's kind of related to rheumatoid arthritis. So I'm using that as an example for how Phil Mickelson would probably be in a wheelchair if it wasn't for these medicines, okay? And he was able to win the British Open. So instead of seeing people like Auguste Renoir, who want, maybe when I was starting out in practice in rheumatology 30 years ago, people were telling me then that they wanted to stay out of a wheelchair. Now people with rheumatoid arthritis are telling me, I want to run the New York City Marathon. So it's really dramatic. So that has provided us meaning those of us who study and are students of scleroderma, the incentive to try to find that immunologic smart bomb for scleroderma as well. We're not there yet, but we're getting closer. And by the way, etanercept is not, while it is used in scleroderma, particularly for those folks who have severe arthritis associated with their scleroderma, it doesn't seem like it is the central problem in our disease. I think the other point I wanted to make was we still don't know actually what triggers rheumatoid arthritis. So we understand the molecular events, or at least a good part of them, that lead to the perpetuation of the disease. And we also have that knowledge now, or increasingly so in scleroderma, but we still don't know what triggers it. And it may be that that actually doesn't matter. And I think that was my point. We don't know what virus causes rheumatoid arthritis in genetically susceptible people, but it may not matter. So what about scleroderma? Well, here's the immunologic chaos and soup again in scleroderma, but instead of having TNF-alpha at the center, it looks like the central sort of master cytokine or cell signal in scleroderma is a different one. It's called TGF-beta. And so we are now searching for an adequate therapeutic agent that targets TGF-beta. We may have it. I think we're on the verge of it. And in the next 5 years, I think we're going to see a lot of interest in medicines that are directed against TGF-beta. But to back up for a second, again, in scleroderma, the rogue effect produces this signaling storm that produces this sort of unique feature of the disease, namely fibrosis, in multiple areas: skin, lung, blood vessels, GI tract, and sometimes the heart as well. So there are other immunologic targets that we're actually actively researching right now. Those include antibodies to type 1 interferon, which is another important cytokine, anti-IL-13, anti-IL-6, but probably this one, I'm hedging my bets on that one. So it's a complex system. There are many potential targets, and we still have to find the right one. And at the same time, we are still pursuing sort of the B52 approach until we can hone down which one of these is sort of the key to the puzzle. So again, to conclude, autoimmune diseases are characterized by an immune system that's gone berserk or awry, with the production of excessive quantities of autoantibodies that produce this immunologic cascade or soup or stew, if you will, that leads to chaos in the immune system and downstream damage and eventually clinical signs and symptoms. I've tried to make the case that developing effective treatment will be dependent on identifying which of those key signaling pathways are the best target. That is the development of an immunologic smart bomb. But I think what's interesting about all this is that it may actually not necessarily require understanding precisely what triggers the disease in genetically susceptible folks, just like rheumatoid arthritis. So why don't I stop there and see if there's any questions about any of that. It's kind of a lot of information.
I think most people agree that stress can aggravate an autoimmune disease, but from listening to you now, I don't think that stress could ever cause an autoimmune disease.
That's right. I think stress is a very difficult thing to study, and it depends on how you define stress. Is stress a physiologic stress? Is it emotional stress, or some combination? I think you're right, though. Although it's difficult to identify and study, I think most people that treat scleroderma patients, as well as all individuals with autoimmune disease, do believe that stress, however you define it, is important in inducing activity of the disease or propelling it, but may not play a causal role. I think there's no evidence, in my opinion, at least to date, that suggests that stress itself is an inciting event. Yes, I agree with that. But it may play a role in adaptation and coping, certainly, absolutely.
Have you noticed or discovered whether any of it is triggered by any environmental issues or any kind of outside irritants that may trigger any of these?
Yeah, it's a good question. Are there environmental triggers for scleroderma in particular? And I think probably the best way to answer that question is that there are examples of triggers for diseases that mimic scleroderma, but not scleroderma exactly itself. An example, it was a number of years ago in Spain, the toxic oil syndrome that induced in many cases, a mimic of scleroderma called eosinophilic fasciitis, the eosinophilia myalgia syndrome. L-tryptophan is another example of a chemical, essentially, which could induce a similar problem. So there are examples of environmental exposures. Bleomycin is another one. Bleomycin, both in humans and in animal models, provokes an intense initial inflammatory and then fibrotic response that mimics scleroderma. Bleomycin was a drug that was left out of Lance Armstrong's testicular cancer regimen because of concern that it would lead to pulmonary fibrosis and affect his ability to get back to the cycling world. He had other issues, of course, that affected his longevity in the cycling world, but But those are examples in which environmental exposures can provoke similar manifestations of the disease. But there isn't really direct evidence that the autoimmune disease itself can be triggered by an environmental exposure.
You had talked about in the next 5 years, you foresee a breakthrough. Can you talk for a moment about some of the research that's going on that may enable that to happen?
Yeah, so I can tell you what we're doing at our place. So we actually have just completed a small open label trial of TGF-beta that was presented in preliminary form at last year's American College of Rheumatology meeting, and we're proceeding with refining and expanding that study, and we hope that that will lead to a larger multi-center phase 2-3 trial to test that therapy. It seems to be safe. We think it's effective, but that efficacy is on a molecular basis. So we can show in a 3-month clinical trial of this antibody directed against TGF-beta that you can see decreases in gene expression profiles that correlate with fibrosis. So I didn't really have time to talk about it, but you can do a skin biopsy now and develop a gene profile of 30,000 genes. You can screen those genes for ones that are associated with fibrosis, including TGF-beta, but also other sort of pro-fibrotic genes. And you can show that with this therapy, that those are all down-regulated or decreased in expression, and that at least correlates in the short term, again, very short time period, with promising but not confirmed clinical benefit. So that needs to be expanded and developed into a larger multi-center trial. That's one example, but we're also looking at antibodies to interleukin-1 and interleukin-6. So they're being pursued by us as well as many others around the country and around the world. We're not there yet, but I think that where rheumatoid arthritis was about 15 years ago, and I think it's just a matter of time before we can hone down and figure out which of this complex array of immunologic targets is the right one. Now, it may not be just one. It may actually be a combination. And so while we look to rheumatoid arthritis as sort of a model disease for understanding how one can target the immune system safely and very effectively, it may not be the perfect model.
In the use of cyclophosphamide to attack the autoimmune system, does this also reduce the appearance of the antibodies such as SCL70 or Rho52 or any of those ones?
It does, and it doesn't do it completely. The best evidence is with very high dose Cytoxan followed by stem cell transplantation. Basically, the pathogenic antibodies, or at least those that are markers of the disease, go away. At lower levels or lower doses, it appears that the levels are reduced, but they don't go away. So it depends on sort of how much you use. If you use an immunoablative dose, they go away. If you use lesser doses, in some cases they persist.
Just a follow-up to my neighbor's question here. You talked about the research in the next 5 years, maybe having an answer. Is your estimate that in 5 years it would be available to the Scleroderma population, or at that point? That's a great question. Sort of what are the regulatory barriers to getting drugs to market, and they are prodigious. There are issues of safety, though, and I'm not trying to defend the FDA, but by 5 years, I estimated that we would have an effective therapy short of regulatory approval and actually
a marketable drug, that may take longer. So, I mean, we'll have to see.
But it's better than where we were.
Yes, I think so. I mean, it wasn't that long ago when scleroderma was considered an untreatable disease. Now, at least we think it's a treatable disease, and I think the next step is a curable disease, or at least using our definition of cure that we use in rheumatoid arthritis, which is that you have a treatment that suppresses the disease. It may mean that you need to continue that treatment to effectively achieve a cure. A cure in the strictest sense, of course, means that the disease goes away and you return to a normal state. That's probably not realistic. But short of that, we think that very effective treatments that will probably need to be maintained to continue the immunologic alteration, if you will, achieved with these therapies, it may be that that's good enough.
And how would one participate in the study that you were talking about with the TGF-beta? And when you're going to a multi-site, which I imagine you're taking it just from your own group to others, for example, maybe the Medical University of South Carolina and what they're doing down there. I mean, any chance that, for example, and what are the attributes of a person with scleroderma that you're looking for? I mean, would it be crest? Would it be diffused, for example?
So that's a good question. So what are the kinds of disease manifestations that we're interested in studying? We think that, and this is perhaps a flaw in the way we have studied the disease thus far, but we think the highest yield is in the people who have the most aggressive disease, and for the time being, that involves individuals who have early diffuse disease. They're changing most rapidly within a given unit of time in terms of both skin and other organ manifestations. And so really for selfish reasons, that is, we are trying to find the most effective therapy in the shortest possible time. We need things to happen quickly. And so we actually target people who are most likely, that changes, I'm not expressing myself very well, but what I'm saying is that we target people who are most likely to change quickly over time so that we can quickly identify changes in gene expression that correlate with the mechanisms we're looking for. And so for practical purposes, that means people with early diffuse disease with a high skin score and disease manifestation or disease onset no more than about 2 years. So that's just the practicality of trying to understand and do something quickly. Obviously, that leaves out the vast majority of people with scleroderma, many of whom have had disease for years. Now that's sort of good news and bad news. Most of those folks, if not a majority, have disease that's burned out, if you will. The disease activity has diminished to a point where it's not changing very much. And certainly I'm not suggesting they don't have problems. They do. They have footprints of the disease when it was active, gastrointestinal disease, perhaps kidney disease, perhaps pulmonary fibrosis, or even pulmonary hypertension. But we're not likely to see changes with this type of targeted therapy in those individuals because their disease, for the most part, there are exceptions, for the most part, the disease isn't active.
Yeah. The challenge that I see is the group that you're looking for. Typically, they're struggling with attorneys or family doctors or whomever, and that to try to figure out what it is. So that time period when everything...
It's a critical time period. You're absolutely right. And we need to get the word out better to find those folks, to capture them, and to try to enlist their help in understanding this early disease process, which is changing quickly. But you're absolutely right. It's a diagnostic challenge. I can't think of a scleroderma patient with early diffuse disease who was recognized quickly and got to our center within 3 months of the onset of their disease. 6 months, maybe a few, most at least a year or longer. So there are tremendous delays in diagnosis that are terrible for people with the disease, but also difficult for us as investigators to find those folks and enroll them in our studies as quickly as we can.